Hello students, welcome to EPG Pathshala. I, Hardeep Kaur, Assistant Professor in Ramjas College, University of Delhi, would like to speak on a very important topic, immunodeficiency, which is included in module Immunity in Health and Disease of paper Immunology. So students, after this lecture, you shall be able to know more about what is immunodeficiency, what are immunodeficiency diseases, mechanism or causes of immunodeficiency diseases, types of disorders, pathogenesis of the immunodeficiency diseases, and methods of diagnosis and treatment of immunodeficiency diseases. Now let's come to the first topic, that is, what is immunodeficiency? Immunodeficiency is the condition in which the immune system is not able to mount an effective immune response against an antigen. The immune system's ability to fight a pathogen is compromised or entirely absent. This can lead to repeated microbial infections of varying severity. Sometimes, it has been seen that the patient can develop enhanced susceptibility to malignancies as well. A person suffering from immunodeficiency is said to be immunocompromised. Such an individual is susceptible to opportunistic infections in addition to normal infections that could affect everyone. Surprisingly, there seems to be a relationship between persons suffering from immunodeficiency and ending up with autoimmunity through perpetual immune system activation. The severity of the immunodeficiency disease is also dependent on the number of components of immune system getting affected. For example, in certain disorders, there is a deficiency of specific immunoglobulin, mostly IgA or IgG. However, in certain cases like SCID, that is severe combined immune deficiency disorder, multiple components of immune system are affected and this can also cause death. Now coming to the history of immunodeficiency, the history of immunodeficiency diseases is interlinked with advances in the field of clinical physiology, microbiology, pathology, along with experimental immunology. However, the first case of immunodeficiency may be defined as the one in a strain of guinea pigs in 1919 by Murray at the Vermont Agricultural Station in Burlington. It was an autosomal recessive disorder with deficiency of a particular serum protein which was later established as C4 protein. The same defect was later found in a colony of outbred Hartley guinea pigs at National Institute of Health, which is commonly called NIH. With newer techniques, almost all deficiencies of complement components, regulators and receptors have also been characterized. Although during first half of 20th century, many patients with typical symptoms of immunodeficiency disorders such as complement deficiency, neutropenia, ataxia telangiectasia, mucocutaneous candidiasis, Wiskottaldrich Syndrome had been reported, the beginning of immunodeficiency is generally considered as 1952 when Ogden, Britain reported the first case of A-gamma globulinemia. The discovery of A-gamma globulinemia by Ogden Britain is regarded as the earliest breakthrough of immunodeficiency disorders. In fact, the disorder has been named after him as Bruton type A-gamma globulinemia. Not only was Dr. Bruton responsible for discovery, he is also credited for finding a specific immunotherapy for this X-linked disorder in the form of intramuscular injections of IgG immunoglobulins. After the first report of X-linked A-gamma globulinemia in 1952, nearly 150 different types of immunodeficiency disorders have been identified. The discovery of immunodeficiency disorders and the molecular characterization of these diseases paved the way for better understanding of organization of immune system. This further led to better immunological diagnostic methods or techniques which led to early detection and better treatment. Classification of immunodeficiency disorders. Immunodeficiency could be due to certain inherited factors, drugs, or certain medical or physiological conditions like infections, pregnancy, aging, or due to numerous other factors. Based on different criteria, These diseases have been variously classified. The most common classification deals with the origin of the cause of immunodeficiency that could either in the immune system or there is involvement of some extrinsic factor causing the disease. Accordingly, they have been categorized as number 1, primary immunodeficiencies. They are the inherited defects of the immune system. They result from genetic or developmental defects of the immune system. Mostly the defects is present at birth, though it may not manifest itself at the time of birth. Primary immunodeficiencies are also called congenital immunodeficiencies. Second, secondary immunodeficiencies. They are the defects that arise due to certain extrinsic factors like drugs or minerals, malnutrition or certain infections. The most common being AIDS or acquired immunodeficiency syndrome due to infection with the human immunodeficiency virus 1, HIV-1. Alternatively, the immunodeficiency disorders are also classified as specific immunodeficiency disorders. These are those disorders in which specific component of the immune system responsible for the condition is known. For example, abnormalities of B and T cells. Or non-specific immunodeficiency disorders. Here, the abnormalities of non-specific components of immune system are responsible for these disorders. It has been seen that in primary immunodeficiency disorders, defects may perhaps be specific or non-specific type. Sometimes the immunodeficiency disorders are also characterized based on the component that is affected as given in this table, wherein we find that if affected components are B lymphocytes, plasma cells or antibodies which are mostly accompanied with hypogammaglobulinemia, then we call it as humoral immune deficiency like chronic lymphoid leukemia or multiple myeloma. However, if affected components are T lymphocytes, then it is T cell deficiency like secondary disorders such as acquired immune deficiency syndrome or AIDS. Affected components are neutrophils, then we call it as neutropenia like chronic granulomatous disease. Affected component is spleen with impaired or no function, then we call it as asplenia, as in splenectomy or sickle cell anemia. However, if the affected component is complement or its deficiency, which could be present in any congenital deficiencies diseases also. Here in this lecture, we have classified immunodeficiencies as primary and secondary immunodeficiencies, as that covers almost all types. Coming first to primary immunodeficiency diseases, we commonly called it as PID. The primary immunodeficiencies involve abnormal development of immune system. It can be due to impaired innate or adaptive immune system. Deficiencies involving adaptive immunity could be due to deficient B cell system or deficient T cell system or both, as there is considerable overlapping between the two, as any deficiency of T helper cell or T suppressor cell will directly affect the antibody synthesis. In most cases, primary immunodeficiency disorders are found to be inherited single gene disorders occurring either in infancy or childhood. However, they can also be present in grown-up children, pubescent and adults. At times, they can be associated with relatively mild clinical manifestation in some patients. Although 50% of defects are those related to B cells, T cell defects almost accounts for 30%. 18% belongs to deficiency in phagocytes and 2% belong to complement deficiencies. The frequency of PIDs has been found to be almost 1 in 10,000 individuals. Another interesting attribute of PID is that 70% occur in males due to X-linked inheritance in many syndromes. For example, prevalence of X-linked lymphoproliferative syndrome is about 1 in 1 million live births in male, and X-linked immunodeficiency with HyperIgM is about 1 in 1 million live births in males again. Primary immunodeficiencies are further classified as humoral immunodeficiencies, that is B-cell defects, cellular immunodeficiencies, that is T-cell defects, combined immunodeficiencies, that is B and T-cell defects, disorders of complement, disorders of phagocytosis. In this lecture, however, we will be discussing the first three types of primary immunodeficiencies or PIDs, while disorders of complement system and disorders of phagocytosis along with secondary immunodeficiencies would be discussed in subsequent lecture, that is part 2. The humoral immunodeficiencies, that is B-cell defects. The B-cell immunodeficiencies could involve complete deficiency of mature recirculating B cells, plasma cells and immunoglobulin, or absence of a particular class of immunoglobulin. Some of the disorders in this category are X-linked A-gamma globulinemia, transient hypogammaglobulinemia of infancy, common variable immunodeficiency or late onset hypogammaglobulinemia, selective immunoglobulin deficiency, which could be IgA, IgM or IgG subclasses, immunodeficiencies with hyper-IgM, trans-cobalamin 2 deficiency as well. X-linked A-gamma globulinemia, also called X-linked hypogammaglobulinemia, XLA, Bruton type A-gamma globulinemia or sex-linked A-gamma globulinemia, also known as Bruton syndrome. These are all different names of X-linked A-gamma globulinemia. The disease was first elucidated by Ogden Carr-Bruton in 1952. It is a rare X-linked genetic disorder that involves mutations in the gene coding for Bruton tyrosine kinase, that is BTK. BTK is a very important gene for the maturation of pre-B cell to differentiating mature B cells. All classes of immunoglobulins are depleted in the serum of the patient. BTK gene is present on X chromosome and therefore the defect is inherited as X-linked recessive and is almost always limited to the sons of female carriers, the mother being asymptomatic all their lives. The symptoms of XLA include repeated and often severe infections accompanied with ear infection, sinusitis, diarrhea due to giardia and pneumonia. The most common pyogenic bacteria responsible for infection in XLA are Streptococcus, Staphylococcus and Haemophilus. The treatment involves immunoglobulin replacement therapy or intravenous introduction of mixture of immunoglobulin, that is IVIG, human IgG antibodies on a regular basis for the lifetime. Transient hypogammaglobulinemia of infancy, that is THI. The immune system in a newborn is not fully developed. Most of the immunoglobulins in neonates are those that were produced by the mother and transferred by the placenta before birth. These immunoglobulins provide protection to the neonates till they start producing their own, usually by age 6 months. Meanwhile, the levels of immunoglobulins from the mother also start decreasing. In infants with transient hypogammaglobulinemia of infancy, there is a delay in the production of normal amounts of immunoglobulins. This results in low levels of immunoglobulins at age 3 to 6 months and back to normal levels at about age 12 to 36 months. The disease may be present in infants of both the sexes. Although the condition rarely leads to serious infections, but few infants develop respiratory or digestive tract infections. This disorder may last for few months to few years, but get resolved without treatment. Antibiotics are often prescribed to combat infections. Certain studies have, however, suggested that THI may be an intrinsic B-cell defect with abnormal antibody responses. Common variable immunodeficiency or late onset hypogammaglobulinemia. CVID is one of the most common symptomatic primary immunodeficiency wherein the symptoms develop around 15 to 35 years of age. It is generally characterized by recurrent pyogenic infections accompanied by malabsorption and giardiasis. The level of immunoglobulins is less than 300 mg per ml. It has been seen that B cells are present at normal levels However, there is defect in their ability to differentiate into plasma cells and secrete immunoglobulins. This also results in decreased T helper cell activity and increased activity of T suppressor cells. Individuals with CVID are more prone to develop certain forms of cancer or lymphoma. The genetic causes of CVID are largely unknown, though mutations in at least 5 genes have been associated with CVID. These include inducible T cell co-stimulator, that is ICOS, along with some other proteins on B cells. The treatment involves intravenous infusion of immunoglobulins. Selective immunoglobulin deficiency, IgA, IgM or IgG subclasses. SIGD or selective immunoglobulin deficiency is an inherited disorder wherein there is selective deficiency of a class of immunoglobulin while the others remain normal or may be elevated in some cases. The most common form of selective deficiency is that of IgA. Most of the IgA in the body is in the seromucous secretions including tears, saliva, colostrum, genital, respiratory and gastrointestinal secretions. As you can see in the diagram, IgA is a dimeric antibody that plays a major role in protecting us from infections in these areas. Though most of the patients do not show any symptoms, however, in some there is increased susceptibility to respiratory and gastrointestinal infections. In some patients, anti-IgA has also been detected. Allergies may also be common in these patients. It has been seen that some patients with IgA deficiency are also found to have IgG2 or IgG4 subclass deficiency. In these patients, the common finding is a maturation defect in B cells to produce IgA. It is not currently possible to substantiate IgA in patients suffering from IgA deficiency, although scientists are currently working on purification of human IgA. The condition gets further aggravated with knowledge that IgA in the serum, unlike IgG, does not remain stable in the circulation for very long. Therefore, there is no effective treatment for this disorder, though antibiotics can be prescribed to combat infections. Selective IgM deficiency has also been found in some patients and is generally associated with septicemia. Immunodeficiencies with HyperIgM Syndrome. In this disorder, there are an elevated levels of IgM and decreased levels of IgA, IgG and IgE. The IgM are normal and have antibody activity. IgM is the form of pentameric antibody that all B cells produce initially before B cells go through class switching due to exposure to an antigen. HIgM is X-linked or autosomal recessive and is accompanied with impaired antibody class switching mechanisms. Patients show enhanced susceptibility to infections along with thrombocytopenia, neutropenia, hemolytic anemia and renal lesions. 5 types of HIgM have been characterized. HyperIgM syndrome, that is X-linked, involves mutation of CD40L gene. Signal from T cells to B cells for class switching is lacking. HyperIgM syndrome type 2, that is autosomal recessive, which involves mutation of the AICDA gene, defection heavy chain production hindering class switching. HyperIgM syndrome type 3 involves mutation of the CD40 gene, B cell not able to receive signal from T cell for class switching. HyperIgM syndrome type 4, which involves defect in class switch C combination downstream of AICDA gene. HyperIgM syndrome, that is type 5, which involves mutation of the UNG gene. Patients with all forms of HIgM syndrome have a severe IgG deficiency and they require immunoglobulin replacement therapy. Cobalamin 2 deficiency. It is inherited as autosomal recessive disorder where there is deficiency of vitamin B12 along with megaloblastic anemia, that is scarcity of RBC and abnormally large sized RBCs that are remaining, and intestinal villus atrophy. Cobalamin or vitamin B12 is obtained from the diet and is found in animal products such as meat, eggs and shellfish. The absence of cobalamin leads to impaired growth, a shortage of blood cells and other symptoms. Those become apparent within the first weeks or months of life. Neurological function is compromised in such individuals and they suffer from progressive inflexibility and weakness in their legs, which is called parapheresis, muscle twitches, myoclonus or intellectual disability. Treatment with vitamin B12 can help in restoration of hematopoietic, gastrointestinal and B cell functions. Video. Now coming to second type of primary immunodeficiencies, that is cellular immunodeficiencies, which is primarily T cell defects. The T cell play a very vital role in immune system. Therefore, any deficiency in T cell would directly affect both humoral as well as cell mediated immunity. This further leads to increased susceptibility to viral, protozoan and fungal infections. Most common intracellular pathogens such as mycobacteria, Pneumocystis carinii and Candida albicans have been found to be thriving in such cases, hence showing the importance of T cells in eliminating these pathogens. Some of the most common T cell immunodeficiency defects are as thymic hypoplasia, chronic mucocutaneous candidiasis, purine nucleoside phosphorylase deficiency. Thymic hypoplasia, DiGeorge syndrome, 22q11.2 deletion syndrome, Princeton syndrome, Villocardiofacial syndrome VCFS, Takao syndrome, conotruncal anomaly face syndrome, that is CTAF, or Sedlakova syndrome, Saylor cardiofacial syndrome, congenital thymic aplasia, thymic hypoplasia, Strong syndrome or colloquially called DGS. These are the different names given to thymic hypoplasia. It is a microdeletion syndrome involving removal or deletion of a small segment on one copy of chromosome 22. The inheritance pattern is autosomal dominant and the ratio at which it is prevalent is about 1 in 4,000. About 90% are de novo, rest are inherited from a parent. The syndrome was described by an endocrinologist, Angelo DiGeorge, in 1968. The exact mechanism that is responsible for different features of the disease are unknown. Of all the deleted genes, that is about 30 to 50, some have been identified as possibly playing a pivotal role in the development of some of the signs and symptoms of the disease. TBX1 is a part of the TPOX family of genes that play an important role in tissue and organ formation during embryonic development. In TGS, point mutation in this gene has multiple effects including abnormal development of endodermal derivatives of third and fourth pharyngeal pouches leading to aplasia or hypoplasia of thymus and parathyroid glands. Since thymus is involved in the development of T cell or cellular immunity, patients with DGS are highly susceptible to intracellular pathogens. They also seem to be more prone to get Parkinson's disease. The FISH, that is fluorescent in situ hybridization test, has made the diagnosis of DGS more precise and more common. No effective cure has been found for this syndrome, though transplantation of thymus can be done in case of a rare case where there is a complete lack of thymic tissue called complete DiGeorge syndrome. Repeated bacterial infections are treated with antibiotics, while cardiac surgery can be done to correct congenital heart abnormalities. Hypocalcemia due to hypoparathyroidism can be treated with lifelong vitamin D and calcium supplements. The syndrome is also known as Catch22, where 22 stands for abnormality in chromosome 22 and Catch for the following features: cardiac abnormality, that is interrupted aortic arch, truncus arteriosus and tetralogy of Fallot, abnormal face, thymic aplasia, cleft palate, hypocalcemia or hypoparathyroidism. Chronic mucocutaneous candidiasis. It is a heterogeneous disorder with impaired cell-mediated immunity against Candida albicans or other species. In many cases, T cells completely fail to recognize the antigen. Patients develop candidiasis of mucosa, nail and skin. Antifungals are useful to control the disease. Purine nucleoside phosphorylase deficiency. It is also called PNP deficiency and is a rare autosomal recessive disorder that causes decreased cell-mediated immunity along with recurrent or chronic infections. The disorder is due to a mutation in the purine nucleoside phosphorylase, that is PNP gene, that is located as chromosome 14q13.1. Enzyme PNP is involved in sequential degradation of purines to hypoxanthine and then to uric acid. Diagnosis can be done by checking the uric acid levels. With this, we come to the third type of primary immunodeficiency defects, that is combined immunodeficiencies, which is B and T cell defects together. The combined immunodeficiencies of both humoral and cell-mediated branches are the worst of all the immunodeficiency disorders, involving multiple components of the immune system. Some of the important disorders that belong to this category are Bcell syndrome, ataxia-telangiectasia, which is also called Lewis-Barr syndrome, Wiskottaldrich syndrome, severe combined immunodeficiencies, most commonly known SCID, and is a very important deficiency. Bcell syndrome or cellular immunodeficiency with abnormal immunoglobulin synthesis. It is an autosomal recessive genetic disorder affecting both males and females. The condition is characterized by absence of T cell function and varying degree of deficiency of B cell mediated immunity. Patients generally have progressively severe, recurrent and eventually fatal infections. It is generally accompanied with thymic dysplasia. Despite the normal presence of immunoglobulins, an antigenic stimulus does not induce antibody formation. Treatment includes monthly injections of gamma globulin or combinations of fresh frozen plasma and heavy use of antibiotics to fight infections. Ataxia-telangiectasia or Lewis-Barr syndrome. It is an autosomal recessive genetic disorder, that is, both parents must provide a copy of a non-working gene to the child to develop this disorder. Cell-mediated immunity is defective along with low levels of IgA and IgE. The combined immunodeficiency in this case is accompanied with cerebral ataxia, that is, ataxia means poor coordination, telangiectasia, that is, which stands for small dilated blood vessels, ovarian dysgenesis and chromosomal abnormalities. Some of the symptoms include decreased coordination of movements, that is ataxia, decreased mental development, discoloration of skin areas on exposure to sunlight, blood vessels are enlarged or dilated in skin of nose, ears, inside of the elbow and knee, and also in the whites of the eye. Jerky or abnormal eye movements, that is called nystagmus, late in the disease, sensitivity to radiation including X-rays, and severe and persistent respiratory infections. Generally, the survival rate is very low. In this slide, you can see how the blood vessels are enlarged in the whites of the eye in ataxia-telangiectasia. This disease is found to be progressive with symptoms of immunodeficiency along with neurological defects getting worse with time. Thymus transplants in fetus and transfer factor therapy are used to treat or control the symptoms. Wiskottaldrich syndrome. The syndrome is named after Dr. Robert Anderson Aldrich, who was an American pediatrician. He described the disease in a family of Dutch Americans in 1954. It is an X-linked recessive disorder characterized by eczema, thrombocytopenia, that is low platelet count, bloody diarrhea, which is secondary to thrombocytopenia, and overall immune deficiency. The syndrome is also called eczema thrombocytopenia immunodeficiency syndrome, as eczema occurs in the first month of birth. Affected boys very rarely survive beyond 10 years due to recurrent infections, hemorrhage, or lymphoreticular malignancy. The female carriers are usually asymptomatic. The levels of serum IgM is very low along with progressively deteriorating cell-mediated immunity. Treatment involves bone marrow transplant or transfer factor therapy. Severe combined immunodeficiencies, also called A-lymphocytosis or Glanzmann-Reiniger syndrome or severe mixed immunodeficiency syndrome, and thymic A-lymphoplesia. The deficiency leads to numerous syndromes involving both cellular and humoral immune responses. SCID is by far considered to be the most severe form of PIDs. Infants with SCID have severe recurrent respiratory infections. Infections are generally serious and at times life-threatening. Other symptoms include poor growth, eczema, chronic diarrhea, etc. Bone marrow transplant is the only cure currently and routinely available for SCID, which provides a new immune system to the patient. In many cases of SCID, it has been found to be associated with X chromosome, that is X-linked recessive, while in others it is transmitted by an autosomal or non-sex-linked recessive gene, that is autosomal recessive. Scientists have found at least 9 different known genes in which mutations lead to a form of SCID. More recently, around 15 different defective genes have been found to be responsible for SCID. SCID is also known as bubble baby disease or bubble boy disease, after the well-known case of David Vetter, as its victims are extremely vulnerable to infectious diseases. As you can see in the slide, we can see David Vetter in his bubble. David Vetter was born in 1971 and he died in 1984 at the age of 12. A specialized sterilized cocoon bed was prepared for Vetter at his birth. Immediately after being removed from his mother's womb, Vetter entered the plastic germ-free environment that was his home for most of his life, hence he was also named Bubble Boy. SCID can be further classified as X-linked severe combined immunodeficiency, which is most common form of SCID that involves mutation in the gene IL-2R gamma, which is located on the X chromosome encoding common gamma chain, that is gamma C, that is shared by the receptors for interleukins IL-2, IL-4, IL-7, IL-9, IL-15 and IL-21. These interleukins and their receptors are involved in the development and differentiation of T and B cells. This leads to non-functional gamma chain and defective interleukin signaling, causing complete failure of immune system. The condition is inherited in an X-linked recessive pattern. Adenosine deaminase deficiency, it is the second most common form of SCID caused by a defective enzyme adenosine deaminase or ADA. ADA is essential for the breakdown of purines. Deficiency of ADA leads to accumulation of DATP. This metabolite will inhibit the activity of ribonucleotide reductase, that is the enzyme involved in reduction of ribonucleotides to deoxyribonucleotides. The efficiency of immune system depends upon proliferation of lymphocytes and hence DNTP synthesis, which gets hampered by non-functional ribonucleotide reductase. The immune system is therefore compromised. Purine nucleoside phosphorylase deficiency, which is an autosomal recessive disorder that involves mutation of PNP gene. PNP is an important enzyme of purine salvage pathway. Deficiency of functional enzyme causes an elevated DGTP level that leads to T cell toxicity and deficiency. Reticular dysgenesis, impaired mitochondrial adenylate kinase 2 that leads to inability of granulocyte precursors to form granules. Omenn syndrome, mutation of the RAG1 or RAG2 genes that prevents VDJ recombination. RAG1 and RAG2 are involved in synthesis of recombinase enzyme that are involved in the manufacture of immunoglobulins. Behr lymphocyte syndrome, which is autosomal recessive. MHC class 2 is not expressed on the cell surface of all APCs, that is antigen presenting cells, due to defective MHC2 gene regulatory proteins. JAK3, mutation in Janus kinase 3 or JAK3 causing SCID. This enzyme mediates transduction downstream of the gamma C signal. Artemis DCLR E1C, that is defective gene called Artemis primarily in Navajo or Apache populations. The deficiency causes severe form of SCID where bodies of children are unable to repair DNA. Now with this we come to the prognosis and prevention of PIDs, which is very important. Now most of the PIDs, that is primary immunodeficiency disorders, discussed up till now are genetic and generally lifelong. In many types of PIDs, the patients can lead a very normal life if the condition is diagnosed early and effective treatment is given. It is known that delay in diagnosis can lead to many complications and sometimes even death in the patients with PIDs. In certain disorders, however, the prognosis is less optimistic and may require intensive care. The genetic counseling of prospective parents who also happens to be carriers can be an effective strategy of prevention of PIDs. Sex determination can also prevent incidence of X-linked disorders. The development of better screening tests for identification of PID is very important. Screening at genetic laboratories as part of prenatal, neonatal and carrier screening programs could be made mandatory, especially for families who are known to have a positive history. Also, specific programs may also be designed for those who are planning marriages within relatives, as this increases the frequency of PIDs. Management of primary immunodeficiency diseases or PIDs. Healthy lifestyle must be ensured for the patients of PIDs. They must be kept in infection-free environment and away from all sources of infections. Regular dental checkup is a must. Live vaccines are never given to patients suffering from PIDs. In fact, killed vaccines may be used whenever required. All kinds of bacterial and fungal infections must be treated at the earliest. In some cases, continuous use of prophylactic antibiotics may be appropriate. Antiviral therapies such as amantadine and rimantadine can be life-saving for the management of viral infections. Treatment may include monthly injections of gamma globulin or combination of fresh frozen plasma and heavy use of antibiotics to fight infection. However, immunoglobulin replacement is contraindicated in selective IgAD as serious anaphylactic reactions can be caused. The best treatment for T-cell deficiency conditions is bone marrow transplant if a suitable donor can be found. Other treatment options may include treatment with cytokines or stem cell transplantation or gene therapy or thymic transplants. So students, let us summarize what we have learnt in this module. Immunodeficiency disorders weaken the immune system's ability to provide an effective defense to the body against pathogen or abnormal cells that attack it, such as it could be bacteria, viruses, fungi, parasites, cancer cells, etc. Primary immunodeficiencies, that is PIDs, are those disorders in which body's immune system is either missing or does not have normal function. Almost all types of PIDs are genetic or congenital in nature. It has also been seen that men are more prone to get immunodeficiency disorders. In most cases, skin, respiratory system, the ears, brain or spinal cord or even the urinary or GI tract, that is gastrointestinal tracts, get affected. Heart defects are also seen in many patients. Many a times, autoimmunity and malignancy are also found to be associated with immunodeficiency. Now, depending on the type, some PIDs are so mild that they can go unnoticed. However, some can be so severe that the bone marrow transplant or stem cell transplant is the only cure. Patients suffering from SCID generally die in infancy. However, research in PID is making great strides, and with efficient diagnosis and new treatment options, the life quality of affected individuals is greatly enhanced.